Hello and welcome to scenario 7 of this AKT podcast. Your question for this case is a 25-year-old patient who's been complaining of variable wheeze symptoms which are exacerbated during exercise and in the summertime. The patient has a normal spirometry results of an FEV1 over FVC ratio of 90% and he's returned today with ongoing symptoms. What would you suggest should be the next stage in your management plan? So in this question, you have a patient with typical asthma symptoms with a normal spirometry test, and the scenario is effectively asking you to demonstrate an understanding of what the clinical investigations are that can diagnose asthma. So for this scenario, I've used NICE asthma guidance as my personal preference, but the BTS and SIGN guidance would also cover very similar points. So please feel free to pause the pod at this moment and have a think about what the diagnostic options could be. So we'll start with spirometry plus bronchodilator reversibility. Now this is a really good test for patients that are symptomatic at the time of testing. If they're not symptomatic at the time of testing, it's not uncommon to have a normal result. Now something else that you could offer the patient is a variable peak expiratory flow reading, and if you have 20% variability between morning and nighttime readings or evening readings over a period of 2 weeks, then this is regarded as a positive result. Now the next investigation to discuss is phenotesting. Now phenotesting is fractional exhaled nitric oxide testing, and this can be used to detect eosinophilic airway inflammation in patients over the age of 17. So in patients over the age of 17, it should be ordered first line, and the limiting factor is whether it's available in the practice or not, or even in the network that you work within. Now, in adults, a result of 40 parts per billion is a positive result, whereas in patients aged between 5 to 16, pheno is only recommended if there is diagnostic uncertainty after the spirometry with bronchodilator reversibility. And in this age group, a positive result is 35 parts per billion. As a side note, as with most investigation, there is a chance of false negatives and false positives, and with pheno, the chance of false negatives and false positives is around 20% for both. And the other thing to consider is if a patient's already been on inhaled corticosteroids, this will impact the result as well, so you may then have a false negative reading. I hope you found this useful, and it's really important to know some of the additional investigations that might be required when making a diagnosis of asthma. In our next scenario, we're going to continue with the theme of asthma. This podcast is hosted by wellmedic.co.uk. We help GP trainees pass the AKT.